So as endocrinologists in treating youth with GID, we play a very different role than we do in other children with endocrine disorders. We play minimal, if any, role in the diagnostic process. And unlike other conditions where we advise about whether to treat and when to treat, with GID youth, our role is really to decide how to treat or advise about how to treat, to advise the medical treatment options and to monitor their effects. So we're really just a prescriber in many respects. And we're involved because GID youth suffer from two conditions that pediatric endocrinologists know how to treat. That is precocity of an undesired puberty and delay of the desired puberty. The three stages in the treatment of GID, divided into reversible, potentially reversible, and irreversible. The reversible stage is that of puberty suppression of that undesired puberty. Potentially reversible refers to the induction of puberty with opposite gender hormone to achieve that desired puberty that's been delayed. And irreversible, we're not involved with as pediatricians because the age limit is 18 for that, and that would be surgery. In terms of the medical management, as Steve talked about, there's some controversy as to when one should start treatment. However, the experts agree that medical therapy is not recommended during the prepubertal years because of the high rate of remission after onset of puberty. We therefore get involved at the time of onset of puberty. And it used to be not till age 16, but in recent years, people have come to the conclusion that the best time to intervene is as soon as puberty begins, ideally 10 or 2. And I'll get into some reasons for that as we go through the cases. And that's for beginning of puberty suppression. We then look at puberty induction with opposite gender hormones at age 16 and at age 18 for surgery for gender reassignment. The criteria for puberty suppression have been well outlined by the experts and professionals working in this field. But the majority really, as an endocrinologist, don't apply to me. There's the mental health professional's role to determine that they meet eligibility for puberty suppression. And the two that I'm involved with are determining whether they've reached at least 10 stage 2 puberty, and then ensuring that there's informed consent and that they understand what the treatment options are and what the potential benefits and risks of those, both for puberty suppressive therapy and then if we progress to that, to cross-sex hormone therapy. He'd been followed by his psychologist for a good 6 months, and the diagnosis of GID had been confirmed male to female. Parents were involved, had been participating in counseling with the psychologist, and were consenting to ongoing and supportive of ongoing treatment. He was 10 or 5, his bone age was 16 years, and he was at adult height, essentially at his adult height of 5'9". He, although he had some feminine mannerisms and behavior, he certainly presented very much a male physical appearance, significant amount of facial and body hair, quite dark hair, which concerned him. He had a prominent Adam's apple, quite a deepened voice, and was fully virilized in terms of puberty. There was no history of substance abuse, and he had a supportive network of friends. To understand the treatment options, you need to understand the hypothalamic pituitary gonadal axis. So the hypothalamus is at the top, and it releases GnRH, or also known as LHRH, luteinizing hormone releasing hormone, which was released in a pulsatile fashion and acts on the pituitary gland to cause the pituitary to make LH and FSH. LH and FSH stimulate the gonads, the ovaries and testes, to make estrogen and testosterone respectively. And if we're looking at intervening there, if we're looking at trying to decrease the sex hormone levels or their effects. And in endocrinology, the best way to do that is to start at the top. So the most effective therapy is to use a continuous form of hormone that would stimulate the pituitary gland on a continuous basis as opposed to that pulsatile fashion that normally would occur with endogenous GnRH. And Lupron, which is an LHRH analog, does this very effectively. It's given, at least in Canada, by an intramuscular injection once a month, and it causes continuous stimulation of the pituitary gland, which results in downregulation at the receptor level and essentially stops the production of LH and FSH, and as a result, there's stimulation of the gonads to make the sex hormones. It works equally well in males and females and is very effective. It is, however, very expensive, $450 a month, which becomes an issue for many of these youth. Depo-Provera is another option which has an effect on gonadotropin secretion, but not nearly as effective, although much less expensive. And so if we don't have an option of Lupron, we tend to look at medications that affect the sex hormone, either their synthesis and or their action. And you can see there's a large list of medications available, either affecting testosterone synthesis or action or estrogen, but none of them are really that effective. They do it to a certain extent. They can decrease the levels of the action, but not as effectively as one would like, and all of them with potential side effects. They are, however, much less expensive than Lupron, and therefore they are often used when one doesn't have a choice for anything else. The problem with effectiveness is because these hormones, these medications don't decrease the levels completely, or the action of the sex hormones, you end up with negative feedback at the pituitary and hypothalamus, which means you still get gonadotropin secretion, which then stimulates the sex hormone production from the gonads. So you're not stopping the problem where you need to, and as a result, you don't have as effective therapy. So it's LHRH analogs that are the gold standard, that the ones that are recommended for treatment, but the cost is prohibitive for many of these youth at $450 per month, with alternative therapy being far less effective. The best results are started at 10 or 2, and the reason for that is both physical and psychological, as I'll explain. I presented the treatment options, and because he had drug insurance, Lupron was an option, and that certainly makes our lives much easier. And so he felt that that was the best option for him. We arranged for the baseline blood work as well as a bone mineral density. We also did sperm banking because although this is reversible, there's potentially long-term effects on fertility, on male fertility. And again, he had family support for the cost of sperm banking, which is quite onerous over the long term. And so he was able to arrange for that as well. And a month later, we signed the informed consent documents, which are produced by these professionals, and as well outlined consents to be used in this situation to ensure that the youth really understand the risks and benefits and what they're going to be starting. And then we started Lupron. He had a good response. He had, in terms of the physical effects, his testes became smaller. He noticed himself that he felt different with his testosterone levels really plummeting. He noticed that his body hair was less. In terms of his overall feeling and libido, that was less as well, and his overall sense of well-being. However, there's no effect on his voice, on his physical appearance in terms of his facial structure and his Adam's apple, because those are really irreversible changes that happen during puberty that we really can't address now at this stage with medical therapy. Having said that, he was overall pretty satisfied with the response, but he was still anxious to begin estrogen therapy. And 8 months later, his psychologist agreed that he was ready to start. And much to my surprise, when we sat down to go over the informed consent document, he then made a decision not to go ahead and said, you know what, I don't need this now. I'm actually feeling okay with where I'm at. And as you'll see with the other case that I presented, that what I've seen with all three kids have been involved with is once we gave them therapy and wrote the prescription, their anxiety levels dropped dramatically because the ball was in their court. And they suddenly felt as if they'd been validated, and the diagnosis had been validated, that there was something they could do about it, and therefore no longer felt that anxiety and pressure to continue with therapy as quickly as they had been prior to receiving the prescription. So he was happy with just sticking with the Lupron. The benefits of puberty suppression are that it, by and large, is reversible, except for that possible long-term effects on male fertility. So ideally, sperm banking is recommended if it's financially viable. As Steve mentioned, it's both diagnostic as well as therapeutic because of that increase in gender dysphoria and psychological distress that occurs at the onset of puberty in many of these youth. And the suppression of puberty may decrease that significantly. If started in early puberty, that may therefore improve the long-term psychological as well as the physical outcome. And it may improve the physical outcome because you can avoid the development of the Adam's apple, the voice deepening, the change in facial appearance that happen with normal male puberty, as well as in females you can avoid breast development and the need for a radical mastectomy, as well as a more female habitus developing. It does, however, require careful monitoring. I'm not going to go into the details. That's really our department, but we're well experienced in monitoring kids on Lupron and on puberty suppressive therapy because we do that all the time for children with precocious puberty. The second case didn't go quite so well. The diagnosis of GID had been suspected but not confirmed by his family doctor of male to female. Parents were divorced. Mother was supportive of his diagnosis and therapy, although I never met her, was said to be supportive. Father was not aware and likely not supportive. 10 of 5, bone age of 16. He was almost 5'11", so tall. Had a male appearance with quite a deep voice, prominent Adam's apple, a slight amount of body hair. He had not come out to any of his friends about his diagnosis and his gender dysphoria. I explained the various hormone options to him, the benefits and risks. I explained that a GID diagnosis needed confirmation by a mental health professional before starting hormone therapy. And I sent him for baseline blood work and a BMD, and then sent him back to his referring physician to help coordinate ongoing therapy and confirmation of the diagnosis. Unfortunately, I really dropped the ball in hindsight by doing that, as 8 months later he was admitted to 6 East with suicidal ideation, polysubstance abuse, to, in his words, dull the pain and agony of living in a male body, said he could not stand to look himself in the mirror, felt that the testosterone in his body was poisoning him, and felt hopeless that things would ever change and unable to cope with the person he was becoming. At that time, he saw psychiatry in-house, and the diagnosis of GID was confirmed, and he was referred back to us in endocrinology. He acknowledged the substance abuse, said he was not attending school, was estranged from his family with no clear means of support. There were concerns about what was going on in the street and activities there. His family doctor had given him a prescription for spironolactone because of the significant anxiety he was facing. In endocrinology, on the other side, we wanted confirmation of the diagnosis and greater psychosocial support and stability before starting treatments. We were really at an impasse there, where he felt that he had to achieve certain things that he was unable to do due to his anxiety and distress and gender dysphoria, and yet we didn't feel comfortable that things were stable enough to support us in treating him at that stage. He became increasingly frustrated with his perceived delays, and he started spironolactone on his own. He also admitted that he ordered high-dose estrogen and progesterone through mail order company, which is widely available, and threatened to start it if endocrine didn't advance the timeline. There was increasing substance abuse and non-adherence with clinic appointments and blood work. So that clearly was not what we wanted to happen, but should have happened. Well, ideally, we would have seen him at 10 or 2 and would have prevented some of that dysphoria beginning, and it didn't happen, and that's not uncommon to have these kids referred late. Even still, had I done a better job, I think, in communicating with mental health and arranging the supports required to ensure that he was getting the therapy he needed, getting confirmation of the diagnosis, we could have proceeded with medical therapy earlier than we had, and perhaps, not necessarily, but perhaps avoided some of that deterioration and distress that he went through. After starting puberty suppressing hormone, he would have been eligible for puberty induction hormones within 6 to 12 months if he met the criteria to continue. And at that point, we would have used gradually increasing doses of gender hormones, the opposite gender hormones, every 6 months, in his case, obviously estrogen, as opposed to starting with high-dose hormones, which had potential physical as well as cosmetic effects. The risks of opposite gender hormones are not benign. On the estrogen side in particular, if you're looking at high-dose estrogen, one worries about DVTs and pulmonary embolism, hypertension, prolactinoma, liver disease, diabetes, breast cancer in the long term, infertility, and effects on bone density, more so with the puberty suppressant, but potentially with puberty induction as well. On the testosterone side, there are also significant risks. And so this is something not to be taken lightly. And although these kids have access to these drugs through mail order and on the streets, you really don't want them self-medicating, ideally. And that's unfortunately what happened with him. And when you do start treatment, you want to be able to monitor them very carefully, as shown here. So as he returned to clinic, he admitted to self-medicating with estrogen and progesterone using higher doses than we would have recommended. And in fact, progesterone is no longer recommended with puberty induction for GID. He had clear breast development, part of which may have been due to the spironolactone, but he clearly admitted to using high-dose estrogen. There was polysubstance abuse. Social supports and mental health follow-up clearly were not there. And so we were, as I said, at an impasse, and agreed that at this point this kid was clearly suffering, clearly things were not going well. We needed to take a step back and readdress what our role was. So we negotiated the next steps and re-examined the respective roles. He agreed to re-engage with mental health. He agreed to work on his substance abuse. He acknowledged that there was no way he could have a real-life experience, as had been suggested to him, because he said he wouldn't pass and he would be at risk of abuse or worse if he tried to have a real-life experience and arrange more social supports and disclosure about his diagnosis. I agreed to communicate with mental health to ensure that we could get confirmation of the diagnosis or other psychosocial supports. And that if he went for the blood work, that I would start, and mental health agreed that we would start estrogen therapy under medical supervision at appropriate doses. We really are the gatekeeper. We have to be careful about that role and that role can be both a good thing and a bad thing. The GID patients often view us as a barrier to them receiving the care that they so desperately want and need. And that may then lead them to feeling that they need to jump through hoops to get what they want. It may mean that we feel manipulated and a power struggle between us. And the best approach is to discuss our role at the beginning, that our role is to help them make informed decisions about how to treat. The decisions about whether and when to treat are the responsibility of the mental health professional, but we can play a role in communicating with them and ensuring that these kids don't fall between the cracks.